of Physiotherapy. I warmly welcome our session chair, Professor Charitha Goonasekara, respected judges, Dr. Sajitra Ilangathileka, Mrs. Lakshmi Jayalat, and all the dignitaries and participants to the technical session 2, parallel session 1, Physiotherapy. First of all, I would like to invite Dr. D.U. Kottachi, Dean, Faculty of Allied Sciences, KDU, to introduce the chair of the technical session 2 of 14th International Research Conference, KDU 2021.
Good morning. Let's introduce the chair of the session, Professor Charitha Goonasekara. Professor Charitha Goonasekara is a professor in biochemistry and she is currently the Dean Research and Development at General Surgeon Kotelawala Defense University. She has obtained her bachelor's degree specialized in biochemistry and molecular biology from University of Colombo in 2002 and Doctor of Philosophy in biochemistry in 2008 from the Memorial University of Newfoundland, Canada. She was also a postdoctoral research fellow at the University of British Columbia from 2008 to 2010. Her studies over the last 19 years have been supported by several research grants and has won awards with include 2 presidential awards and some grants from National Science Foundation and University Grant Commission as well. One of her research projects won the NSF Research Awards of the year in 2018 for the most successfully completed research project funded by the NSF. Also, she is a 2-time Barnum Travel Awardee from the Memorial University of Newfoundland, Canada in 2002. She won the gold medals for Ghulam Hussain A.J. Noorbai Award for the most outstanding student and the Stanley Vijay Sundara Memorial Award for the best results in biochemistry and molecular biology from University of Colombo. The research programs initiated by her in variety of study fields have represented in many publications and presentations in both national and international journals. Also, she is a research supervisor for postgraduate students in almost every year and have produced several doctorates from KD. She was a former head of the Department of Preclinical Sciences in Faculty of Medicine, KDU. Currently, the prestigious lady in the director of KDU CARE, the Multidisciplinary Research Institute of KDU as well. And in addition, she was the chairperson of 8th International Research Conference, KDU in 2015. Madam, you are an asset to the FHS as well as KDU. So I warmly invite you to chair this session.
Thank you, sir. I will now hand over to Professor Charitha Goonasekara to conduct the session forward. Over to you, madam.
I'm humbled at your words, nice words, Dr. Darshana. Thank you very much. So yeah, about to begin the technical session 2 under the Allied Health Sciences. This is a parallel session 1 on physiotherapy. So there are 6 presentations that we are going to hear today. And we have 2 judges for the session, Dr. Sajitra Ilangathileka and Ms. Jayalat. Let me first introduce Dr. Sajitra to the panel. Dr. Sajitra Ilangathileka is a senior lecturer in the Department of Clinical Sciences, Faculty of Medicine, KDU. She has completed her MBBS and Doctor of Medicine from University of Colombo and obtained the membership of Royal Colleges of Physicians from United Kingdom. She has specialized in rheumatology and currently working as a consultant rheumatologist in University Hospital KDU. Her teaching area and research interests lie in internal medicine, rheumatology, and medical rehabilitation. Then Ms. Jayalat, Ms. Lakshmi Jayalat is a senior lecturer at the Department of Allied Health Sciences, Faculty of Medicine, University of Colombo. She is a CEDA accredited teacher in higher education, teaching multiple subjects in physiotherapy for undergraduate students as well as for postgraduate students. She is also a visiting fellow of La Trobe University, Australia. Ms. Jayalat is the chairperson of the research stream of the BSc Physiotherapy undergraduate curriculum and the Secretary of Research and Higher Degrees Committee, Faculty of Medicine, University of Colombo. She graduated from Faculty of Medicine, University of Colombo, and completed her Masters of Philosophy in Physiotherapy from La Trobe University, Australia. Her key research interests lie in sports physiotherapy, musculoskeletal physiotherapy, and rehabilitation fields. So I welcome both Dr. Charitha and Ms. Jayalat to this session for their involvement, contribution as the judges to today's panel. Then I want to give some housekeeping rules for today's presenters. So I will announce the title of the presentation and the presenting author at the beginning of each presentation. You will be given 10 minutes for your presentation. At the 8th minute, there will be a bell rung, and at the 10th minute, the bell will be rung for twice, and you are supposed to finish your presentation by 10 minutes. Then there will be a 5 minutes question and answer session at the end of each presentation. So at this time, the session will be open for the live audience as well as the virtual audience, as well as for the judges to ask questions and get the clarifications on the presentation. Yes, I think we can start the session now. Let me introduce the first speaker for today's session. Okay, Weerarathne will be talking to us today on the relationship between early physiotherapy intervention and shoulder joint mobility among breast cancer survivors in Sri Lanka. Over to you.
Good morning, everyone. I am Weerarathne, and I am here to present the study regarding the relationship between early physiotherapy intervention and shoulder joint mobility among breast cancer survivors in Sri Lanka. So this is the overview of this presentation. The introduction part first. I'm starting up with the cancer statistics in Sri Lanka in 2020 among female population with cancers. This was evaluated by Global Cancer Observatory, and as you can see the pie chart, pink color area, more than 25% of female population with cancers were diagnosed for having breast cancer. And also it plotted the first out of top 5 most frequent cancers. So in here, what is a breast cancer? It's a malignant tumor, and usually it originates from the cells of the lobules and ducts of the breast, and they are growing up to the nearby healthy breast tissue, which make them allowed to grow into the lymph nodes of the underarm. So there are many types of treatment options available for breast cancer, such as local treatments and systemic treatments. Under them, there are surgery, radiation therapy, chemotherapy, and hormonal therapy. Among surgical opinions, modified radical mastectomy was thought to be an ideal surgical management for most of the stages in breast cancer due to its better survival effect. This surgery was introduced in 1948 in the London hospital, and this procedure removes the entire breast, including the skin, areola, nipple, and most of the axillary lymph nodes. Why this is important for us? Because though this surgery has a better survival effect, the breast cancer survivors has to struggle with many types of post-surgical complications after the surgery that affect them in a physical, psychological, functional, and social aspects in their life. So among these complications, for our study, we focused on one common frequent complication that breast cancer survivors suffer, which is shoulder joint mobility impairment. There are previous studies that showed up the relationship and the prevalence of shoulder mobility impairments after the modified radical mastectomy surgery with axillary clearance. Since the man could stand up with 2 legs, man used to get the maximum uses and advantages using upper limbs. Among upper limb structures, shoulder joint is very important due to its greater mobility. In this figure 5, you can see the basic movement of the shoulder joint which allow us to maintain a better day-to-day life activities. They are shoulder flexion, extension, adduction, abduction, internal rotation, and external rotation. As I have mentioned earlier, there is a probability of getting shoulder mobility impairments after modified radical mastectomy with axillary clearance, and also there are previous studies that show that physiotherapy interventions can prevent and limit these impairments. And the problem in here in Sri Lanka is the time to commence physiotherapy, because some patients are referring just after their surgery, soon after their surgery, whereas some patients are referring after the HS. So let's move into the justification with our collected facts. Shoulder joint mobility impairments lie as a front-leaning complication for the breast cancer survivors after their surgery. And there's a delay to commence physiotherapy in some patients. Therefore, considering these two factors as much more important, but there were no previous studies in Sri Lanka that we could find regarding these two factors. Therefore, we made our objective as to identify the relationship between shoulder joint mobility and delayed physiotherapy among breast cancer survivors in Sri Lanka. Now it's the time to give you an overview of our methodology. Our study design was a cross-sectional study, and the study sample was 74 female breast cancer survivors at Apeksha Hospital, Maharagama. And we included the participants who were newly referred to commence their physiotherapy for the Department of Physiotherapy within our study period, July 2020 to February 2021. And we included the participant who followed modified radical mastectomy surgery with axillary clearance. And in our study, we excluded the participants who had a history of shoulder joint injuries or other pathologies of shoulder joint before their surgery. Regarding data collection, we obtained our ethical approval from EIC KDU and Apeksha Hospital, Maharagama, and we collected the socio-demographic data of our participants using a pre-tested interviewer-administered questionnaire. One of our main variables in our study is delayed period to commence physiotherapy. In here, we had taken the time period from the surgery date to the date of the first date of presentation to the Department of Physiotherapy to commence their treatments for each participant. Regarding shoulder mobility, for each shoulder movement, we assess the active range of motion using a universal goniometer in standard positions and using specific landmarks. In this figure 6, you can see how we measure the active range of motion of shoulder joint one movement abduction in one of our participants. Let's move into the results. We analyzed our data using SPSS version 23, and our total sample was 74 female breast cancer survivors, and the age of the sample ranged from 35 to 7 years, whereas the mean age was 54 plus minus 8 years. In this chart, this gives you an overview of the distribution of delayed period to commence physiotherapy. So as you can see, here we have categorized our participant sample like less than 1 year, 1 to 5 years, 5 to 10 years, and so on. So this less than 1 year period means the participants who had commenced their physiotherapy within less than 1 year period of their surgery. And as you can see, the most of the participants in our sample were referred and commenced their physiotherapy within 1 to 5 years of their surgery. This table gives you the descriptive statistics of shoulder mobility. For each movement we assessed the minimum value, maximum value, and the mean values. And as our data sample was normal, we moved forward with parametric test Pearson correlation test in order to find out the relationship between our main two variables, delayed period to commence physiotherapy and each shoulder movement. As you can see, for each shoulder movement, the results reported that there's a significant negative relationship was found in between these two factors, and also especially this was allowed for all the 5 movements. And also the highest value was recorded with flexion active range of motion with delayed period to commence physiotherapy. Let's move into the discussion part. There was a significant negative relationship found in between our two main variables, delayed period to commence physiotherapy and shoulder joint mobility, and especially for each movement of the shoulder joint we assessed. And also there are previous studies that show the similar outputs. As some examples, there are the studies conducted in Denmark, Brazil, and also in Korea. Let's move into the conclusion part of our study. As I have mentioned, our results showed that there's a significant negative relationship in between delayed period to commence physiotherapy and shoulder joint mobility. There are previous studies that showed shoulder joint mobility impairments can reduce with physiotherapy interventions. So it is important to commence early physiotherapy interventions for these breast cancer survivors who had followed their modified radical mastectomy surgery and with axillary clearance. So we are recommending for the patients to participate in early physiotherapy interventions in order to reduce their shoulder mobility impairments, and for the healthcare workers to encourage the patients and refer the patients on time to participate in their physiotherapy interventions, and also with the future researchers to assess the effectiveness of physiotherapy interventions in increasing active range of motion among breast cancer survivors in Sri Lanka. And also in our study, we had gone through the active range of motion only, and he is invited to conduct a research on passive range of motion of shoulder joint affection with these early delaying physiotherapy interventions also. Here are my references and the acknowledgements. For the participants of the study, Department of Physiotherapy staff at Apeksha Hospital, Maharagama, and Dean, staff of Department of Physiotherapy, and our colleague from Faculty of Allied Health Sciences. And here is my email address. And for any inquiries or further information needed regarding our study, please feel free to contact me. And thank you all.
Okay, thank you, Ms. Weerarathne, for keeping on time as well for your excellent presentation. Now, the forum is open for questions for Ms. Weerarathne.
I'm Dr. Charitha. I have two questions for you. One is, did you analyze the age range of this group of patients? And the other thing is, depending on the range of movement of the shoulder, were you able to find any clinical pattern? Because at the end of the day, for these patients to be referred to physiotherapy, clinicians should detect it, whether they are having a rotator cuff pathology or a frozen shoulder. So were you able to identify that in your study?
The first question, ma'am, yes, we did assess the age range. It ranged from the 35 to 70 years actually in our sample. And for the second question, we didn't analyze that part actually, but there were previous studies that showed there are structural changes occur with modified radical mastectomy surgery and breast cancer treatment for sure, but we didn't assess this part in our study.
This is Lakshmi, and I have two questions actually. How many of your participants after the surgery had secondary complications where they could not be referred for physiotherapy, or did you all identify any particular reason that there was a lag behind referring to physiotherapy? And the second question is, how did you minimize the measuring bias? Because you took the data from via the goniometer. So, how did you reduce the bias in taking during the measurement?
For the first question, ma'am, for the first question, ma'am asked that did we, can please repeat the first question, ma'am?
So yeah, did you all identify any complications, secondary complications after the surgery that the patients had?
Yeah, for the most of the time, these patients, there's a pattern, ma'am. Most of the time, these patients are referring due to the lymphedema cases because they have their lymphedema and heaviness of the limb. That's why they are referring most of the time, rather than that after their radiotherapy treatments and completing their chemotherapy treatments, they are referring. That's why most of the patients are delaying to commence their physiotherapy treatments in here. And also for the next question, to reduce the bias, we have taken the three measurements for each movement and taken the average value for our value for taking in here. That's why we reduce the measurement bias in here.
Do we have any more questions? Yes, we have a question from the live audience. Yes, please go ahead.
My question is, you have taken the active range of motion.
Yes, sir.
You take the range of motion and the muscle power.
Not the muscle power, sir. Just actually the active range of motion only.
Yeah, why can't you take passive range as well?
We didn't perform because these patients are suffering with some kind of illness, sir, in here. So they had some kind of pain naturally. So we didn't do it. So in this study, that's why we recommend the study to carry out in passive range of motion also in further.
Okay, I have one question, Ms. Weerarathne.
Yes.
Yes, this is just like a general question for curiosity. In your results, I saw that there was a difference in the number of patients in each category for the delayed physiotherapy action. So, would you think like that would have affected your results, the interpretation of your results, the differences in the number or the frequency of your categories?
Actually, ma'am, most of the participants will commence their physiotherapy after even 1 to 5 years of this period. So it's actually a delay. So they have already gone with the time period without physiotherapy intervention. So I don't think that it will affect our results because actually more than 1 year means actually delayed period to commence physiotherapy in these patients.
Okay, so do we have any questions? Any more questions? So in the absence of any more questions, can we wind up? Okay, thank you very much, Weerarathne, for the excellent presentation. So we'll move on to the next presentation for today's session. So the second presentation is on comparison of lower extremity intrinsic factors between non-contact anterior cruciate ligament injured and uninjured elite football players of the Super League in Sri Lanka, presented by J.S. Keshara. Over to you. Mr. Keshara, can you start the presentation?
Good morning to everyone present today. Good morning to one and all present today. I'm Keshara Srikanth, Physiotherapy undergraduate of the Faculty of Allied Health Sciences, Sir John Kotelawala Defence University. Today, I'll be presenting our undergraduate research on the comparison of lower extremity intrinsic factors between non-contact anterior cruciate ligament injured and non-injured elite football players of the Super League in Sri Lanka under the paper ID 209. So as we all know, most of the audience who are present here would be huge fans of football, and I hope that this research is also as intriguing to your interest. So to start off with the introduction of our research is based on the well-known fact that non-contact anterior cruciate ligament or ACL injuries is one of the most frequently occurring injuries among football players. The main reason for this would be that the mechanism of the injury is very closely related to the football activities such as pivoting, jumping, and decelerating. And it is also to be noted, once a player has an injury, there's a very great negative impact on the player's performance due to the long periods of inactivity and return back to sport, as well as there could be a major negative impact on the player's quality of life due to the secondary complications such as early onset of osteoarthritis, as well as the socio-economic factors that the player might face, such as the expensive treatment methods that are available for the injured. So our research understands the necessity of identifying lower extremity intrinsic factors that could relate to the injury, and also to identify certain clinically relevant assessment methods which has been utilized in our research methodology as well, that could also be used in like football club and ground settings and not only in clinical settings. So this way football clubs can actually establish preventive programs to screen the players during the selection process for any kind of intrinsic factors, and then lower the risk of ACL injuries by directing them towards early intervention.
Okay, Ms. Keshara.
Yes.
Thank you very much for the presentation, and my apologies for pronouncing your name wrong earlier.
No, that's all right.
Yes.
She's still, yes, still presenting the thing. Yeah.
So the objective of the study was to determine the association of lower extremity intrinsic factors that are available among non-allied football players with non-contact ACL injury in Super League of Sri Lanka. So according to that objective, here you can see a picture of the available lower extremity intrinsic factors that could affect football players and provoke the non-contact ACL injury. So to start off with the methodology of our research is a retrospective case study. And as our study setting, we have included 5 major football clubs of the Super League, including the winners of the Super League in the last tournament, which would be New Youngs, Defenders, Blue Eagles, Colombo Football Club, and Seahawks Football Clubs. And the study population for our research was male allied football players who have a history of non-contact ACL injury within 3 years, as well as without a history of non-contact ACL injury, which I will explain how it falls under each category. So the inclusion criteria for the case group was the history of complete non-contact ACL injury. They should have the history within 3 years, and they should currently be in a competitive level, carrying out sport activities, and they should provide a granted written consent. The exclusion criteria was that they cannot be undergoing any kind of physiotherapy treatment for non-contact ACL injury or postural malalignment. And they cannot be having multiple joint injuries in the same limb as the limb that has the non-contact ACL injury. So here our study is a retrospective case study, as I've already mentioned. Our research sample was 31 male allied football players who were divided into 2 groups as the case group and the control group. The case group had football players that had the ACL injury history within 3 years, and there were 15 players in that group. And the control group had football players without ACL injury history, and they were considered as the control group with 16 players. Players for the case group with the history were actually diagnosed by a registered orthopedic surgeon, and the diagnosis card was provided during the selection process. And that's how the case group was made. So the study tools and instruments that have been used in our research would be: first, an interviewer administered questionnaire was given to the player to obtain their demographic, sport injury, as well as past medical history. This questionnaire was also pre-tested outside of the study population. And then the height and weight were measured of the player using standard methodology, and the mean values of this were used to calculate the body mass index. Finally, the intrinsic factors that were assessed in our research would be: first, pronation of foot. So we assessed this using the navicular drop test, where the difference of the navicular height in weight bearing and non-weight bearing positions were measured using a vernier caliper. And then the foot arch height, or the plantar arch morphology, was assessed using the Staheli plantar arch index, where the width of the central region of the foot and the width of the heel region of the foot were divided by one another to provide an index. Tibial torsion and femoral torsion, which is the rotation of the tibial and femoral bone, were measured using goniometric measurements. All these measurements were assessed by, for each measurement, a separate invigilator was assigned, and that invigilator measured it across the population with the same equipment to reduce the bias. So under results, our results were analyzed in the SPSS software 26. And first, the normality of the test was assessed by the Shapiro-Wilk test. Once the results were normal, the data was used for further parametric tests. The mean age of the population was 22 years, and the mean BMI was 21.3 to the nearest kilogram per meter square, which is, according to the full classification of BMI, it's the normal. It falls under the normal BMI category. So first, the demographic characteristics of age, height, weight, and BMI were compared between the 2 groups. As shown in the table, there was no statistically significant difference between these parameters among the 2 groups. Second, the intrinsic factors were compared between the injured and non-injured group. The mean values were used, and an independent sample t-test was done. Again, there was no statistically significant difference for any of the intrinsic factors between the injured and non-injured group, as shown in the table below. Finally, the intrinsic factors were compared between the affected limb and non-affected limb within the injured group. Here, as mentioned before, since it is within the same group, a paired sample t-test was done. And as shown in the table below, navicular drop, which is the assessment done for pronation of foot, was identified as an intrinsic factor that showed a statistical difference when compared between the affected limb and non-affected limb within the injured group. So after the key findings, before we go to our conclusion, let's look at our discussion. So the similar results with our research would be: first, BMI has been considered as a baseline parameter, according to previous researchers, BMI is actually identified as a factor that influences non-contact ACL injury. So to eliminate the effect of BMI in our when assessing for intrinsic factors in our results, BMI was first neutralized as a baseline parameter between both groups. Second, hyperpronation of feet has already been identified as a major risk factor for non-contact ACL due to the greater ground reaction forces that are produced in the player. So in our result also, a similar result was seen. And finally, the non-neutral position of foot and ACL injury. Not many researchers have been done to identify their relationship, but with available researchers, we can say that there is no relationship among non-neutral position of foot and ACL injury. The very significant negative result that we saw was femoral torsion and tibial torsion has already been identified as predictive factors for non-ACL. Non-contact ACL injury. The reason for that would be that femoral torsion and tibial torsion in their researchers has been assessed using a motion analysis system that identifies the impact of these factors on non-contact ACL in different phases of the gait. We could not get access to such extensive equipment, but I can assure you that our methodology was clinically relevant and also much more feasible in our situation. So finally, for conclusion, pronation of foot has been identified as an intrinsic factor that influences the lower extremities for non-contact ACL injury. And therefore, football clubs as well as management should also identify this factor and direct them to appropriate intervention programs to lower the risk. And other intrinsic factors such as femoral torsion, tibial torsion, and plantar arch morphology have not been identified as significant risk factors for non-contact ACL injury among elite football players in Sri Lanka. So under recommendations, I would recommend that this research is carried forward by including the other football, professional football teams, also in the Super League, the remaining 5 teams, so that it represents a larger sample size and represents the football population of Sri Lanka. Another factor to be assessed would be the female football players. So that way the influence of gender on the prevalence of non-contact ACL injury could be assessed with these intrinsic factors as well. These would be my references. And thank you all for your patience. I have mentioned my email here, and if you all have any further inquiries regarding the research, you can contact me through this email. Thank you very much for your patience.
Okay, thank you, Keshara. So I'm going to invite the forum to ask questions from Ms. Keshara now, from the live audience as well as from the virtual audience.
This is Lakshmi. Thank you for the presentation. Did you consider about the other types of injuries in the football players, especially in the control group?
Yes, during our interviewer-based questionnaire, we usually take past medical history, their sport history, as well as sport trauma history. In the injured, usually we consider the lower extremity for our research. So both lower extremities were assessed for any kind of injury history, and it was mentioned that they did not have any injuries in the control group.
Right. And did you identify what is the most common type of injuries found in football players in Sri Lanka?
Yes. When we were going through previous literatures, it has been a research has been done in 2017 to identify the most prominent injuries that occur among football players. 83.9% of the injuries occur in the lower limbs, and 43.5% of them go towards knee injuries. And ACL is one of the most commonly occurring injuries among these players, and 70% of those injuries account for non-contact ACL injury, which is why we chose to assess them based on these intrinsic factors for non-contact ACL injury.
What about ankle sprains? Is it the commonest, or how did you find literature on ankle sprains for football players?
In comparison to knee injuries and ankle injuries, 43.5% occurred for knee injuries and 38.5% occurred for ankle injuries. So due to the prominence of knee injuries and ACL injuries, we chose to assess them on these conditions.
Okay. And is there a particular, my last question actually, is there a particular reason why you excluded muscle strength, lower limb muscle strength?
The reason why we chose to exclude lower limb muscle strength, there's no particular reason for that. It also has been identified as an intrinsic factor. But the reason why we choose these 4 intrinsic factors is the interconnectivity between these 4 factors. The interaction, that is femoral torsion, could affect tibial torsion, and that could affect, there's an interaction that occurs between the 4 intrinsic factors that we assessed. So due to that reason, we have chosen the 4 intrinsic factors.
All right, thank you.
Thank you.
So I have 2 questions for you. Did you assess the severity of the ACL injury in these players? And number 2 is, now you have found a significant association with the hyperpronated foot. So
Yes.
if you found the severity, like how severe was the hyperpronation induced injury on the ACL?
The severity of non-contact ACL injury, the way we assessed it was that when the players were called, when we were making the inclusion criteria, we chose players who are in the competitive level. So players who are in the competitive level already have undergone the necessary strengthening as well as return back to sport training required. So the severity of the injury was comparatively less during our research procedure. They've already healed from the injury. And in our results, the measurement of hyperpronation of foot, when it was taken, the measurements actually fell under the category of hyperpronation of foot. So with saying that pronation of foot is an intrinsic factor, it is actually also, it can also be mentioned that hyperpronation of foot is what causes the player to go under non-contact ACL injury.
Keshara, I have a question from you.
Yes, sir.
So as Dr. Charitha said, did you analyze the degree of the injury? That means, is it a grade 1, grade 2, grade 3? Is it healed from grade 1? So that's why we asked actually.
Okay, sir. So actually, when we chose the players were chosen under like a registered orthopedic surgeon. The diagnosis card that was given by him, by assessing that card only, and most of the time the players had undergone grade 2 or grade 3 injury of ACL.
Following a reconstruction surgery.
Not everyone had undergone in grade 2. Not everyone had undergone a reconstruction, but grade 3, the players had undergone reconstruction.
So yeah, if you selected the grade 3 players, so
yes,
after how long that you have entitled to your research, that means how many months of rehabilitation you went?
Actually, sir, our research, we considered players with a history within 3 years. So the reason for that was due to the COVID situation, there was a period of quarantining and off season. So they were all past the rehabilitation period of 9 to 12 months. So after that, 1 year of lockdown and quarantining in off season. And again, in 2021, when they were back to the competitive level or sport activity, we chose them.
Okay, thank you. Thank you.
Okay, so thank you.
I think there is one more question we can accommodate from the audience.
Yes, hello, Ms. Keshara.
Yes.
For just curiosity, I need to know, what do you mean by intrinsic factors here?
Intrinsic factors here, what we mean is the anatomical and biomechanical factors that are present within the lower extremity of the player. So the difference in alignment of foot or the difference in anatomical position of the joint factors.
Okay. Did you go through any extrinsic factors related to your research?
In previous literature, it is also noted that non-contact ACL injury has extrinsic factors. But within the extrinsic factors is usually the environment in which the player plays, like playing surface, meteorological conditions, shoes, such that. So to assess them, extensive equipments will be needed. Since it's not accessible, we chose to do intrinsic factors only, and also so that the research is much more specific to intrinsic factors only.
Okay, yes, it's very clear. Thank you.
Thank you.
Ms. Keshara, I have just one question.
Yes, ma'am.
Now, when you take these measurements, when you collected your data, did you consider because these football players, they play for a long time, right? Like when they
Yes,
play. So when you collect the data, did you consider of collecting data just after a activity, or like when did you collect the data while they were in resting, or just after sports activity or something because that I'm just wondering whether that would have changed your results if you have collected data in a different manner.
Yes, madam. Usually, we chose during our data collection period. Most of the football clubs were actually in a social bubble for their tournament, and we were only allowed in the ground for the measurement activities. And most of the time, it was in the morning periods, just after their warm ups. So we were allowed due to COVID, we also had to practice social distancing, and only one player was allowed during the measurement. But we made sure that that time is uniform throughout the research. All the measurements were taken only in that particular morning time, just after their warm-up exercise session.
They have been on activity, right?
Yes.
At the duration. Okay.
Yes.
Thank you very much, Ms. Keshara,
Thank you.
for your excellent presentation. Thank you very much.
Thank you, ma'am.
Congratulations. So next move on to the third presentation for today. It is on the relationship between craniovertebral angle with the long-term usage of electronic devices among undergraduates of General Sir John Kotelawala Defence University, presented by Ms. ALNK Perera.
Thank you, madam.
Please go ahead.
Good morning, respective panel of judges and my dear colleagues. I'm ALNK Perera from Department of Physiotherapy, FHS KDU, and I'll be delivering our research presentation on relationship between craniovertebral angle with the long-term usage of electronic devices among undergraduates of General Sir John Kotelawala Defence University. So first of all, I would like to give you all a small introduction regarding our research. As you all know, many undergraduates tend to use electronic devices such as smartphones and laptops, often for their daily activities as well as for their academic purposes. So when considering the long-term effects which could be resulted due to this problematic usage of smartphones and laptops, we can just mention them in related to both psychological and musculoskeletal systems. Among them, forwarded posture has been identified as the commonest postural abnormality seen with the individuals who use these smartphones and laptops for a prolonged period of time. And based on previous studies, it has been stated that craniovertebral angle, which is the angle formed between the horizontal line passing through the 7th cervicospinous process and the line passing through the tragus of the ear, as the best indicator to measure the severity of forwarded posture. So what our intention was to carry out a research to find out whether there's any relationship between craniovertebral angle and long-term usage of smartphones and laptops among undergraduates of FHS KDU. And these were our specific objectives. It was to evaluate the relationship between CV and BMI, and to evaluate the relationship between CV and duration of time using smartphones and laptops per day, and to determine the association between CV and gender. Moving on to the methodology, we have carried out a descriptive cross-sectional study by recruiting 228 undergraduates of intake 36 and 37 by the consecutive sampling method. And as the inclusion criteria, we have recruited undergraduates who were in the age category of 19 to 24 years and who were using both smartphones and laptops for more than 1 year of time, and who grant written informed consent were included, while the undergraduates who had previously detected as having any cervical spine injury or any congenital spinal deformities, plus who didn't grant written informed consent, were excluded from the study. And moving on to the data collection, prior to data collection, we have attained our ethical clearance from the Ethical Review Committee of General Sir John Kotelawala Defence University. And afterwards, we started collecting our data by using two main methods. As the first main method, we have used a self-administered questionnaire, which was pre-tested and validated by us. And that questionnaire was used to assess their long-term usage of smartphones and laptops. And as the second main method, we used photographic method in analyzing their craniovertebral angles. Then the whole procedure was divided into three different stations as station 1, 2, and 3. In the first station, we just distributed all information sheets, consent forms, and the self-administered questionnaires among participants. And also we recorded their height and weight to get the BMI measurements. And in the second station, we did palpation of 7 cervical vertebrae and the tragus of the ear, and we placed 2 adhesive markers on those 2 reference points. In the third station, we did capturing the lateral view photographs in order to get the craniovertebral angle, as you all can see in this third figure. And after capturing the photographs, we imported them into the Kinavier software, which is a motion analysis software. And data entry and analysis were done by using IBM SPSS software version 20. Then as parametric tests, we have used Pearson's correlation coefficient test and independent sample t-test to evaluate the statistical relationships. Moving on to the results of our study, this table 1 demonstrates the descriptive statistics of the demographic characteristics that we have concerned. Among them, as the mean age, we found it out as 21.83 years, and mean BMI was 22.84, which was almost, which most of the participants were in the category of normal BMI, and mean duration of years using smartphones was 4.93 years, which is almost 5 years. Mean duration of years using laptops was 3.91 years, which is almost 4 years. And in this figure 4 and 5 are the scatterplot demonstrations of correlation between CV and duration of years using smartphones and laptops among undergraduates. So based on these respective P and R values and the scatterplot demonstrations, we have come into a conclusion that there's a significant negative correlation between craniovertebral angle and duration of years using smartphones as well as laptops among undergraduates. And moving on to this slide, figure 6 is the scatterplot demonstration of correlation between CV and duration of time using smartphones per day. So there we found out that there's a significant negative correlation between CVA and duration of time using smartphones per day. And in this figure 7, as you all can see, we found out that there's a negative correlation between CV and duration of time using laptops per day, but it was not significant. Then this figure 8 demonstrates the scatterplot demonstration of the relationship between CVA and BMI values of the participants. There we found out that there's a significant negative correlation between CVA and BMI values of the participants with a p-value greater than 0.01 and an R-value of minus 0.55. Then to evaluate the association between CVA and gender, we have used independent sample t-test. According to that, we have found out that there's no significant difference in the craniovertebral angle of females and males. So these are key findings. A statistically significant negative linear relationship was found out between CV and long-term usage of electronic devices among respondents. And a statistically significant negative linear relationship was observed between CVA and the time duration of using smartphones per day. And a moderately negative significant correlation was observed between CVA and BMI values of the participants. And also we found out that there's no significant association of craniovertebral angle in relevant to their gender. Moving on to the discussion, based on our results, it was evident that participants who were having lower craniovertebral angles were reported as long-term users of these electronic devices, whereas the people who were reported with normal or relatively higher craniovertebral angle were short-term users of these devices. So this observation proves that many people tend to use these electronic devices in a head-shifted forward position to keep staring at these devices, which can likely reduce their craniovertebral angles. And also participants who were having larger BMI values were reported with lower craniovertebral angles, which indicates that these electronic devices, the people who use these electronic devices in an excessive manner might exhibit a sedentary lifestyle, which might predispose them to gain more and more weight. And also there were no noteworthy differences between CV of males and females, which was in agreement with Vanetta 2016. So finally, as the conclusion of our study, it reveals that undergraduates are more susceptible to use these electronic devices in an addicted manner, which can decrease their craniovertebral angles and in turn leading to forwarded posture. Therefore, long-term usage of electronic devices have an impact on the cervical spine posture among undergraduates, which in long run can result in any other musculoskeletal dysfunctions. So as the study limitations, it was quite a big challenge for us to recruit a large number of sample size during this pandemic situation, and also lack of prior researches conducted relevant to this topic was another limitation that we have come across with. And these are our references. Finally, I'd like to extend my heartiest gratitude to our research supervisor, Dr. Vasantika Thuduwage, for her precious role in making our research a success. And also a big thank must go to our Department of Physiotherapy, and the Dean Sir, FHS KDU, and also each and every participant who took part with us during the study. Last but not least, I'd like to thank our parents for their immense support and guidance provided us throughout the research procedure. And this is our take-home message. Lift the phone, don't drop your head. Thank you so much.
Thank you, Ms. Perera, for the nice presentation and also keeping on time. So now I invite the forum to ask questions from Ms. Perera. So you have recruited 228 undergraduates. So what is the breakdown of the faculties? Like, are they all from the same faculty?
Yeah, ma'am. All of them were from our faculty because of the easy accessibility, and also with the available time, we could only access into our faculty.
May I ask you a question? Now, how did you rule out the other variabilities? Like these are undergraduate students, right? So apart from using the smartphone or the laptop, they would be using books, kind of using the same posture, isn't it? How did you rule out those variables?
Because, ma'am, we have selected to find out the relationship between craniovertebral angle and the electronic devices. So among the electronic devices, like the most convenient electronic devices that usually undergraduates use are the smartphones and laptops. So that's why we have selected this.
Yeah, I understand that. But my question is, like, they would have been using other, not like, besides the electronic appliances, they would have been using the same posture while they are reading or like doing their writing or during the lectures and all. So those are variables which you have to consider in your study, right? Like, can you come to this conclusion that the only reason for this negative correlation for this angle of is due to the use of electronic devices? There can be other variables also causing them to be bended, right?
Yes, ma'am, but we have not considered about those factors in our research.
And about the duration of their use of these devices, did you consider that?
Yes, ma'am.
Okay.
The time duration was analyzed in our study.
Okay, right. Are there any questions for Ms. Perera from the live audience? Or
Navini, so what about the postures that they had? Did you take these photographs in sitting position or lying position, or what are the postures? Do you have any photos?
We have taken the photographs in the standing position. So that was selected because based on previous literature studies, we have found out that the most sensitive posture to measure the craniovertebral angle is the standing posture than the sitting posture. So we thought of getting the measurement in the standing posture during our study procedure.
Okay.
I have one question. This is Ms. Lakshmi. And when you're in your discussion, you mentioned something about this angle being associated with the posture. So when you can look at the posture, did you consider the posture while they're engaged or they're using the computer or the smartphone? Is that important when you measure the posture without just looking at the crane, their standing normal craniovertebral posture? Is it important to measure it while they use the device? Is it, how did you work out that?
Yeah, ma'am, we have asked about, like, from our questionnaire, we have asked from them what is the most preferred posture while using these smartphones and laptops. And it was like they have several different postures while using these smartphones and laptops. But in our study, we just measured it in the standing posture as it is the convenient way. Like, we can't go and assess their postures while they use these electronic devices. So that's why we selected the standing position to get the measurement of CVA.
All right, thank you.
Thank you so much, ma'am.
There's one more question from the audience.
It's a good topic. And are you sure there is no previous research on this one, ma'am?
So there were no such literature was available in the Sri Lankan context, but there was one literature study which has been conducted among Nigerian students. So that was the only research which is conducted relevant to this topic.
Okay. A vascular accident only we know, but you say it in a full form. Okay, thank you.
Thank you so much.
Do we have any more questions for Ms. Perera? Yeah, I think the time for discussion is also over. So I would congratulate Ms. Perera for the excellent presentation.
Thank you so
very
much.
So we'll move on to the fourth presentation for today's session. It is on the correlation between incidence of falls and quadriceps muscle strength among patients with COPD from 2 selected government hospitals in Colombo district, presented by Ms. Malsri, DGS Malsri.
Thank you, madam.
Yes, please go ahead.
Good morning, all. I am very grateful to you all for being here to listen to my presentation. I am Sandali Malsri, undergraduate physiotherapist from the Faculty of Allied Health Sciences, General Sir John Kotelawala Defense University. The topic of our study was the correlation between incidence of falls and quadriceps muscle strength among patients with COPD from 2 selected government hospitals in Colombo district. Outline of the presentation is on introduction, objective, methodology, results, discussion, conclusion, recommendations, references, and acknowledgements. First of all, let me give you a brief introduction about our study. In patients with COPD, skeletal muscle dysfunction involves with both respiratory and peripheral muscles. Lower limb muscles are more severely affected than the upper limb muscles. Out of all the muscle groups of the lower limb, quadriceps muscle group is more severely affected than the other muscles. Due to the reduced quadriceps endurance, the patients with COPD will have reduced working capacity, and it will cause excessive accumulation of lactic acid in the calf muscles of the lower limbs, causing the higher incidence of falls. And also, there are no previous studies to determine the relationship between quadriceps muscle strength and the risk of falls in the COPD patients in Sri Lanka. Also, this study will be beneficial in identifying the changes in COPD patients to include the treatment plans to the physiotherapy rehabilitation to get the maximum outcome of the physiotherapy rehabilitation. The objectives of our study was to identify the correlation of falls incidence and quadriceps muscle strength of patients with chronic obstructive pulmonary disease, to evaluate the probability of risk of falls in relation to quadriceps muscle strength of patients with chronic obstructive pulmonary disease. Moving to the methodology part, the study design was a descriptive cross-sectional study, and the study sample was a convenient sample of 35 COPD patients. The inclusion criteria were the patients, the both male and female patients with COPD between the age group of 40 to 60 years, and all the patients with who has diagnosed with COPD under the Global Initiative for Chronic Obstructive Pulmonary Disease. Exclusion criteria were the patients who had experienced the exacerbation within 4 weeks, patients with ongoing treatments for pulmonary infections, patients with previous surgeries such as lung surgeries, cardiothoracic surgeries, and lower extremity joint replacement surgeries, and the patients with neuromuscular conditions like Parkinson's disease, osteoporosis, and arthritic conditions. Ethical approval for the study was obtained from the Ethical Review Committee of General Sir John Kotelawala Defence University and the directors and chief physiotherapists of respective hospitals, and informed written consent was obtained from the participants.
Miss Malsri, we can't hear you. Are you there?
Madam, my screen is stuck. Give me a second,
Yes.
please. Data collection method. In order to measure the quadriceps muscle strength, 1 repetition maximum strength test was conducted with the use of free weights, which could be strapped around the ankle. Prior to the test, all the participants were given instructions on how to perform the test. The test was performed in the seated position, and subject was then instructed to stretch the testing leg forward up to 180 degrees with the corresponding weight. 2 familiarization sessions were performed by conducting 5 repetitions with the application of lowest weight. The participants were given a random initial load that was reduced or increased accordingly to suit the ability of each participant to perform the 1 repetition maximum test. If the participant could lift the weight more than once, the weight was increased until the individual failed to lift the weight more than once through full range of motion. All the participants were given 2 minutes of rest between each attempt. Number of incidents of falls during the last 3 to 6 months was obtained through an interviewer administered questionnaire. The results of the study, the collected data was analyzed using SPSS version 23 software. The mean value and standard deviation of age were as follows. Table 1 shows the relationship between right side quadriceps muscle strength and the risk of falls among the COPD patients. And the table 2 shows the relationship between left side quadriceps muscle strength and the risk of falls among the COPD patients. According to the Spearman's rank correlation coefficient test results, there was a statistically significant moderate positive correlation between the right side quadriceps muscle strength and the risk of falls. Table 2 shows the relationship between left side quadriceps muscle strength and risk of falls among the COPD patients. Similarly, there was a statistically significant moderate positive correlation between left side quadriceps muscle strength and the risk of falls. Table 3 shows the probability of risk of falls among COPD patients in relation to the level of right quadriceps muscle strength. Table 4 shows the probability of risk of falls among COPD patients in relation to the level of left quadriceps strength. According to the logistic regression test results, there was a statistically significant positive relationship between the right quadriceps muscle strength and the risk of falls. Similarly, there was a statistically significant positive relationship between left side quadriceps muscle strength and the risk of falls. Discussion. According to the study conducted by the Laurent et al. In 2020, there is a significant moderate positive correlation between left and right quadriceps muscle strength with falls incidences of patients with COPD, which is similar to the results of our study. Conclusion. This study concludes that there is a significantly positive correlation between falls incidence and quadriceps muscle strength of COPD patients. Further, there is an increase of probability of not falling in parallel to the improvement of bilateral quadriceps muscle strength with increase in severity from moderate, severe to very severe stage of COPD respectively. Recommendations. It is recommended to include balance exercises and lower extremity strength training exercises to the pulmonary rehabilitation programs. Also, it is recommended to include carry out similar studies with a larger sample size considering the COPD population in Sri Lanka. These are the references of our study. Acknowledgement. The authors would like to thank the chest physicians and physiotherapists of the respective clinics for their assistance in collecting patients for the study. We highly appreciate and extend our sincere thanks to all the patients who actively participated in this study without making any objection. Thank you. Have a nice day.
Thank you very much, Ms. Malsri, for your excellent presentation. Now invite the forum to ask the questions.
I have several questions. Any particular reason for you to choose COPD patients?
Yes, madam. During our clinical practices, we had the chance to go to Weerarathne Chest Hospital mainly. So there were COPD clinics. So we had the chance to encounter with those patients, and we had the chance to identify what are the weaknesses with them. And so we were interested about that topic. So we wanted to search about it, and we find out more literature about that. And we found that this is a good area to discuss. So that's why we selected this topic.
During your literature review, were you able to find out any other medical conditions? Because there are several other conditions which could give rise to the same association.
Yes.
Can you name some of them?
Like bronchitis, emphysema, asthma.
Apart from pulmonary, like because the renal failure patients can have skeletal muscle dysfunction, heart failure patients can have.
Yeah, those arthritic conditions, neuromuscular conditions like Parkinson's disease, stroke patients, and also with the elderly population, like with the age also, this can affect.
My last question is, there can be other confounding variables. Now, even within COPD, patients can have, the severity can change, and the patients can have anemia, pulmonary hypertension, those things which can affect the risk of falls. And there can be other extrinsic factors which could affect the falls. So did you consider those things when you are taking, like, enrolling these patients into your study?
Yes, madam. Because that is why we excluded the patients who had surgeries with patients with lung surgeries, cardiothoracic surgeries, especially with joint replacement surgeries, and also the patients with ongoing treatments for pulmonary infections, they may have the balance impairment and also the falls risk, and that's why we excluded those patients from our study. And also we excluded the elderly population because with the age also the balance criteria can affect to the falls incidence. That's why we have included 4 to 60 age group also.
We have a question from the virtual audience.
Sandali, I have a question for you.
Yes, sir.
You analyzed the quadriceps muscle strength and the prevalence of the incidence of falls among COPD patients. What about the general population? So did you compare, have you had a control group for that? So do you have any idea about the general population, the relation between quadriceps muscle strength and the risk of fall?
Actually, sir, we didn't include control group to our study. We wanted to do only in the COPD population because we interested onto that one. From the general population also, I think there is a high influence from quadriceps muscle strength, quadriceps muscle weakness for the falls risk.
Okay, thank you.
I have two questions. First question is, you gave a recommendation saying that balance exercises should be incorporated into the exercise program of a COPD patient. So what type of a balance deficit did you identify in your sample? And I'll finish my question. And the second question is, you looked at falls. And what type of falls did the patient have? Did you analyze that data? Is it during a lack of ventilation? Is it during in-house? Is it, out of the house, in the garden? Were there any obstacles? Was it, due to something else, any other medical? Because falls has multiple roles. So did you analyze what type of a fall was it?
Okay. For the first question, ma'am, in our study also we considered about the balance also. So we found that there is a relationship between static balance, dynamic balance, and the functional balance also. Those each categories are affecting in the COPD patients. And to the second question, my answer is we considered about the falls, but we asked about the history of falls in the patients with COPD. We didn't ask about whether it is from unlevel surface or anything. Just we asked about the falls history, whether they have any falls history between 3 to 6 months of the disease.
I think Prasanthi Dabare, if you are still there, you can please go ahead asking the question. The hand was raised earlier, I saw among these participants who have joined virtually. There was a question earlier. If you are still there, you can ask question. Okay. Are there any more questions? Right. So I have one more question. Actually, it would have been nice, Sri, if you had at least compared your correlation among the same relationship between this quadriceps muscle strength and the general population. How the correlation between these two among the general population is related or compared to your results. Because I feel like this could be a general feature as well, like in the general population, not just specific to COPD patients. And if you have done the same study with non-COPD patients, whether you would see the same results.
I think, madam, because most of the general population, most of the people don't engage in more exercises, and especially they don't consider about strengthening and all. So I think we have to mainly focus on strengthening quadriceps, the calf muscles, because they are the main muscle groups which affect in the balance and also the maintaining our body posture and all. So I think this will be relate to our normal population as well.
Our time is also up. Thank you very much, Ms. Malsri, and congratulations. We will move on to the fifth presenter of this session. The title is Level of Physical Activity and Changes in Lifestyle-Related Behavior During COVID-19 Pandemic among Undergraduate Medical Students of Faculty of Medicine, University of Colombo, Sri Lanka, a cross-sectional study presented by Ms. Pramodini. Please go ahead.
Could we please enable me to share the screen? Thank you. Good afternoon, everyone. First of all, I would like to thank all the organizers of the KDU International Research Conference for giving me this opportunity. I'm Shanshika Pramodini, and our study is on level of physical activity and changes in lifestyle-related behavior during COVID-19 pandemic among undergraduate medical students of Faculty of Medicine, University of Colombo, Sri Lanka. Co-authors of this study are Dr. A.H. Vettasinghe and Mr. Samir Madhusankar. As you all know, COVID-19 pandemic has become a public health burden globally. Not only the disease itself, but also the social distancing measures and related lockdown have led to several physical and psychological problems among people at all ages. As outdoor activities are limited, working from home and online classrooms became the new normal in many countries, leading to several difficulties in achieving the recommended levels of physical activity. So this lack of physical activity could lead to chronic health conditions, including non-communicable diseases such as coronary heart disease, type 2 diabetes, and cancers, thus shortening the life expectancy. COVID-19 affects not only the physical health, but also the mental health as well. It is reported that people experience psychological stress, depression, anxiety, and insomnia during this COVID-19 pandemic. So it is also reported from recent evidence, it is reported that there is a significant difference in physical activity levels and energy expenditure before and during the COVID-19 pandemic. Moreover, it is reported that the prevalence of overweight and obesity has been increased, especially in the youth population. Even in the non-pandemic period, university students were prone to unhealthy dietary patterns and unhealthy lifestyles, which led them to sedentary behaviors. This is even more common in the medical students due to their tight academic schedules. So this COVID-19 pandemic could lead them even to a greater risk of sedentary behavior. Thus, the objective of our study was to identify the level of physical activity and changes in lifestyle-related behavior during COVID-19 pandemic among undergraduate medical students. Another objective was to identify the gender difference in physical activity level and sedentary behavior. Assessing physical activity and lifestyle in medical students would be beneficial in many ways. As future healthcare professionals, they themselves can adapt to a better lifestyle at this stage, and once they become professionals in the future, they can advise their patients on the importance of following an active lifestyle. Speaking of the methodology, this was conducted as a descriptive cross-sectional study, and we used convenient sampling to recruit participants. Study setting was Faculty of Medicine, University of Colombo, and study population were undergraduate medical students. 244 participants joined for this study, including 110 males and 134 females. To assess the physical activity level, we used the International Physical Activity Questionnaire short form, which is also known as the IPAC-SF. According to the IPAC-SF, we classified physical activity level according as vigorous physical activity, moderate physical activity, and walking. Also, in those activities, we measured the total metabolic equivalent minutes per week. To assess the changes of lifestyle, we use the lifestyle-related behavior questionnaire, which is known as a reliable tool to be used in the COVID-19 pandemic. Statistical analysis was done using the SPSS version 25, and we used independent sample t-test to identify the gender difference in physical activity level and sedentary behavior. Ethical approval was obtained for this study from the Ethics Review Committee of the Faculty of Medicine, University of Colombo. So these questionnaires were distributed among study participants using online methods, and we gave them a 2-week period of time to respond. And after the given time frame, access was denied to the e-survey. So if you look at the results, you can see that majority of the participants were physically inactive, which is shown in the blue color. 47.13% of the participants were physically inactive during the COVID-19 pandemic. 43.44% of the participants were moderately active, and only 9.42% of the participants were highly physically active during this pandemic. This graph shows the total metabolic equivalent minutes per week according to each gender. So the MET minutes represent the energy that is expended while you are doing physical activities. So 1 MET is equal to the energy that is expended while you are at rest. And according to the American Society of Sports Medicine, we considered walking to be equal to 3.3 METs, and moderate physical activity to be equal to 4 METs, and vigorous physical activity to be equal to 8 METs. So here you can see that there is a difference between physical activity level, a significant difference between male and female participants, where males outperformed females. So this gender difference identified in the physical activity level might be due to several reasons. It might be due to the different motivations, different interests, and environmental influence. As I mentioned earlier, we classified the physical activity levels as vigorous physical activities, moderate physical activities, and walking. Here also, you can see that male participants have had higher physical activity levels in all 3 categories. Sedentary behavior was identified according to the sitting time, screen time, and sleeping time per day. If you look at this graph, you can see female participants had slightly higher sedentary behaviors when compared to male participants. However, the differences between these values are not statistically significant. In changes of lifestyle-related behavior questionnaire, 44% of the participants reported that their sleeping hours were slightly increased during the COVID-19 pandemic when compared to the pre-pandemic period. Also, interestingly, 75% of the participants reported that their screen time was significantly increased. This might be due to the shifting of on-site teaching and learning activities to online teaching, and maybe due to the home confinement. Moreover, 75% of the participants reported that their sitting time was also increased significantly during this pandemic. So these are the major findings of our study. In conclusion, as majority of the participants were physically inactive during the COVID-19 pandemic, there is a need of policies to promote indoor physical activities and active lifestyles among undergraduate medical students. So we hope it would be beneficial in managing secondary complications associated with physical inactivity and sedentary lifestyle. So our results are also in line with other studies, because most of the studies have also found that there is a decrease in physical activity levels when compared to the pre-pandemic period in university students. So we hope that the impact that COVID-19 has brought to the disruptions of our daily lives could be seen as an opportunity to improve better habits and to lead an active lifestyle. So I would like to thank Dean and the academic staff of the Faculty of Medicine, University of Colombo, and undergraduate medical students of the Faculty of Medicine, University of Colombo, for their support given during this study. These are my references. So that, well, that brings to the end of my presentation. Thank you very much for listening.
Okay, thank you very much, Ms. Pramodini. Now the forum is open for you to be asked questions of. Okay? Please ask questions from Pramodini. Right, I have one question, Ms. Pramodini.
Yeah.
Now, when you collected the data, did you actually ask the participants to measure the duration of each activity before they?
No, ma'am. It was done by us. In the IPAC SF questionnaire, the questions are usually asked in the last 7 days, how was your vigorous physical activities and how was your moderate physical activities, like that.
Okay, so have they given a duration?
Yeah, duration. Yes, yes.
So is it
20 minutes per day, like that.
Right. So has it been an estimation, or like they have actually measured how much they have been walking, or like?
Yes.
Yeah.
Yes, ma'am. Yeah.
Okay, good. Shanshika, I have a correction for you.
Yes.
In your study, you have mentioned about undergraduate medical students. So in
Yes.
which year, first year, second year, the final years, what is the group you have selected?
We considered all batches, first year and final
Can
year.
you justify why you selected the medical students? Because
Yes,
compared to the other undergraduate students, medical students, they used to go for clinicals and their exams. They didn't stop anything compared to the other degree programs. So why you selected the medical students for this?
Yes, that's a very good question, sir. So we considered medical students mainly because once they become healthcare professionals in future, they can advise their patients on the importance of these. And also their academic schedule is very tight when compared to other university students. So it is known that medical students were prone to sedentary behaviors even in the non-pandemic period. So.
Okay.
Shanshika, I have 2 questions for you.
Yes.
What was the respondent rate for your question from your participants? Respondent rate.
It's we got more than 95% of respondents.
And
yes.
Did you consider about the BMI
Yes.
or weight?
Yeah, madam. Yeah, we categorized participants according to the BMI categories. Most of the participants were normal weight. And also we analyzed whether there are differences in physical activity level between each group, but we did not find any significant differences according to the BMI category.
And did you look at, because when it comes to the moving from, you mentioned something about from on-site to online. So I assume that the screening time would be equivalent to the seating time of the participants, during their lectures, because they will be either seated again, it will be considered as a sedentary. So did you identify any differences between the on-site seating time and online screening time?
Madam, we did not assess the sitting time in pre-pandemic era, how the sitting time would be. We did not assess that due to recall bias, madam, because we did this data collection in this year in April. So this COVID-19 started in last year, March. So assessing the pre and post physical activity levels would lead to recall bias. So we did not assess that, like pre and during the pandemic, likewise.
Okay, thank you.
Thank you, ma'am.
Do we have any more questions for Ms. Pramodini? Okay, in the absence of any more questions, shall we move on to the next session? No, thank you very much, Pramodini, for the excellent
Thank you very
presentation.
much.
Congratulations. So our final presentation for today's session is on prevalence of evidence-based physiotherapy interventions for children with cerebral palsy in Colombo district, Sri Lanka, cross-sectional study, presented by Ms. D. Silva. Over to you, please.
Good afternoon, everyone. For the 4th International Research Conference of General Sir John Kotelawala Defence University, our research topic for oral presentation is Prevalence of Evidence-Based Physiotherapy Intervention for Children with Cerebral Palsy in Colombo District, Sri Lanka, a cross-sectional study. I am Suchin Janthi Silva. My supervisor is Senior Lecturer Grade 1, Pediatric Faculty of Medicine, Kotelawala Defence University, Dr. G.D. Shani Rodrigo. And my co-supervisor is Lecturer, Department of Physiotherapy, Faculty of Allied Health Science, Mrs. T. Pravina. What is cerebral palsy? Cerebral palsy is the most common cause physical disability in childhood. Cerebral palsy is a permanent disorder that occurs in developing brain. It is non-progressive and it causes posture, movement, sensory, cognition and behavioral disturbances. Then we looking into prevalence of cerebral palsy. Globally, it is 1.2 to 2.5 in 1,000 live births. Even though there are no researchers done cerebral palsy interventions in Sri Lanka. Around the world, 2020 suggests that prevalence of cerebral palsy in Sri Lanka may be at least 0.2%. The reason we chose this topic is because there are very few researchers conducted physiotherapy pediatric field in Sri Lanka. There are no researchers conducted regarding the prevalence of evidence-based physiotherapy intervention among cerebral palsy children in Sri Lanka. By doing this research, we believe that it is a great opportunity to present the quality of physiotherapy interventions in management of cerebral palsy. Also, by doing this research, we can give a clear and broad idea to what effective physiotherapy management are. Let's move on. Objective on our research. Our general objective is to evaluate the evidence-based practice of physiotherapy intervention among the children with cerebral palsy in Colombo District, Sri Lanka. Our specific objectives are to describe evidence-based physiotherapy or physiotherapy interventions with different age groups, gross motor function classification scale levels, and different CP subtypes. And also finally to determine the commonest and earliest age range of children with cerebral palsy preferred for physiotherapy intervention for cerebral palsy in Sri Lanka. Let's move on to methodology of our study. Our study settings are physiotherapy unit of Lady Ritchie Hospital, Colombo, Rheumatology and Rehabilitation Hospital, Ragama, Colombo North Teaching Hospital. Our study period was 1st of February to 4th of March 2021. Our study design was a descriptive cross-sectional study and sample size was 100. And also our inclusion criteria were patients who gave consent, children who were medically diagnosed with as cerebral palsy, age groups starting from birth to 2 years, 2 to 4 years, 4 to 6 years and 6 to 12 years. And sample method is most convenient sample method. And we excluded patient who didn't give a consent, caregivers with children about 12 years, and caregivers who gave any difficulties in understanding the patient. Initially, we interview the parents and obtain details from them. Then we observe physiotherapy intervention techniques that were used among the children. Our main data collection tool was grade system and evidence allowed traffic light system. We obtain list of physiotherapy interventions from this tool. We used to update an evident traffic light system published in 2020. It is a criterion standard evident grading tool. It is an updated version of 2013 article and which is endorsed by the World Health Organization in 2020. This traffic light system considers 45 interventions and 80 outcomes. The outcomes we divided in 3 colors: green, yellow, and red. Green means it is a do it, and yellow means it is a probably do it. In red means it is a don't do it. And our other data collection tool was gross motor function classification system and ethical clearance. We gave ethical review committee, Faculty of Medicine, Kotelawala Defense University, and our data entry and analysis method was statistical package for social science SPSS version 22. Let's move research findings. First, distribution of evidence-based practice intervention among population. 45 interventions observed, 33 interventions the traffic light system are practiced in the Sri Lanka, but 12 are not practiced. The study finding discovered that play therapy 93%, strength training 93%, and mobility training 91%, goal-directed training 80%, bimanual 79%. Only play therapy result yellow outcomes. That means probably do it. 4 other intervention result green outcomes. Interventions which result green outcomes are proven effective interventions according to the evidence allowed traffic light system. Through the frequency analysis calculated the mean values for number of green, yellow, and red outcomes obtained by the single child in the population. Then 3 mean values represented percentages result as follows: green do it 40%, yellow probably do it 57%, red don't do it 3%. According to the traffic light system, our study sample the highest distribution of the yellow outcomes and lower distribution for the red outcomes. So it shows the Sri Lanka pediatric physiotherapy management is at a better level and could be further improved. Next, according to different age groups, different gross motor function classification scale levels, and different subtypes, there is no considerable difference in the prevalence. According to the descriptive frequency analysis and visual interpretations like bar chart, pie chart, play therapy, mobility training, strength training, goal-directed training, and bimanual were interventions which have highest demand in all groups. Next, when considered the percentage of children involving in early intervention, age groups was birth to 2 years shown to percentage of 69%. This is a good sign shown in pediatric physiotherapy in Sri Lanka. According to age group, children among who were to 2 years, birth to 2 years, birth to 23 months, are commonly found to have cerebral palsy showed in percentage of 33%. When considering the distribution of gross motor function classification scale levels, in grade 3 category and is the very highest category in 28%. According to distribution of cerebral palsy types, spastic diplegic cerebral palsy was the most common in Sri Lanka, showed in percentage 30%. Finally, our conclusion was majority of the practice intervention result in yellow outcomes, and it means Sri Lanka pediatric management is at a better level and it could be further improved. Play therapy, strength training, and mobility training intervention are used in 3 clinical settings for all age ranges, gross motor function classification levels, and all cerebral palsy types. Our main limitation is COVID-19 pandemic situations, and these are our references we used. And finally, I would like to thank every and each one who helped and support to our research study success. Thank you.
Thank you very much, Ms. De Silva. Now the forum is open for questions for Ms. De Silva.
Thank you for that wonderful presentation. I have two questions. First one is, what were your settings? You observe children who were treated. Was it the public, or whether it's the government hospitals, or whether it's the private clinics that you observe? The second question is, who did the observation? Was it one person, one investigator? And whether the investigator was confident enough to assess the therapists who were doing the practice?
We use government hospitals. They are in Colombo District, Wijerathne Hospital, Colombo, and Rheumatology and Rehabilitation Hospital, Ragama, and also Colombo North Hospital, Colombo North Teaching Hospital. Second section, we observe, ma'am, in our groups has 4 members. In our 1 member is getting the questionnaire and subjective assessment, and our other 3 members going to 3 clinical settings and observe. If we have a infection, we ask in main physiotherapist and in clear what is the incorrect intervention.
And do you think if you observe in the private sector, the private clinics where the cerebral palsy children are treated, what do you think? Will you receive a different result? Do you have any idea about that?
Ma'am, I think also it's in same results.
Okay, I have several questions. One thing is, now we have taken 100 participants for the study. Am I right? Yes.
Yes.
Yes. So did you analyze them according to the topological distribution, like how much of them are quadriplegics, how much of them are hemiplegics, like that?
Yes.
Pardon?
Yes.
So can you tell me something about it? Like
in most of the cerebral palsy child, we found in spastic diplegic. In least number, ataxic and dyskinetic type.
And where does CIMT falls in your traffic light system? Constraint induced movement therapy? I saw it put in your chart, but it didn't fall into any of your traffic lights. Constraint CIMT?
Yes, ma'am. We only select the highest number of intervention in practice.
Do we have any more questions? Yes, we have a question. Yes.
You have taken 100 children. So you have started in February and March. So is it you are able to take 100 children within that short time?
Yes, sir. They are in 3 clinical settings.
So there are a large group of children with spastic CP.
Yeah, in Wijerathne hospitals, in warded patients and outcomes OPD patients came daily 20 or 30.
Okay, so there are different types of interventions you have listed.
Yeah.
So how did you come to the conclusion that this is the intervention, task-specific training, or this is CIMT, or this is the... So you have marked the percentages. So how did you do that?
So we observe in physiotherapists done the techniques, and we observe what is the intervention is, and we select. If we had the question, we ask the physiotherapist what is the intervention is, and we select.
So you check the physiotherapist who is doing the intervention and you have come to the conclusion.
Yes.
So was there any other limitations you had? You have told only the COVID pandemic was the limitation. Was there any other limitations in your study? There should be a lot of limitations.
Yeah. In other limitations, we we got in birth to 12 years only, but 12 to 18 we can got.
Do we have any more questions? Okay. Thank you very much for the excellent presentation, Ms. B. Silva. Congratulations.
Thank you.
Yes. So we have come to the end of today's session, the technical session 2 of Allied Health Sciences, which is on physiotherapy. I think we had an excellent session with fruitful discussion at the end of each speech. To sum up the session, I would like to remind, first we were listening to a speech on the relationship between early physiotherapy intervention and shoulder joint mobility among breast cancer survivors. Then we were listening to another presentation on the comparison of lower extremity intrinsic factors between ACL injured and uninjured elite football players in Sri Lanka. Then also we listened to a talk on the relationship between CVA with the long-term usage of electronic devices. Then the fourth presentation was on the correlation between the incidence of falls and the quadriceps muscle strength among the COPD patients. Then we also listened to an excellent speech on the level of physical activity and changes in lifestyle-related behavior during the COVID-19 pandemic among medical students. Then finally, we listened to the talk on the prevalence of evidence-based physiotherapy interventions for children with cerebral palsy in Colombo district. So it is the end of this session. And I like to thank all the audience who have joined virtually as well as on site with us here for your excellent participation for a productive session on physiotherapy. Thank you very much.
Thank you, Madam. And I would like to invite the Dean, Faculty of Applied Sciences, Dr. D.U. Kotelawala, to present the mementos as the token of appreciation to the chairperson and judges of this session for their participation and valuable cooperation. Please. Madam, please accept the mementos. Okay. 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 So we'll invite our Professor Charitha Goonasekara, Madam, to present the token of the mementos to Judge Dr. Charitha Ilangathileka. Thank you, Madam. Now I invite Dr. D.U. Kotelawala, our Dean, Faculty of Applied Sciences, to present the memento to our chair, Professor Charitha Goonasekara. Thank you, Madam. Now I would like to invite Sukirtan to receive the memento on behalf of Mrs. Lakshmi Jayalat, our next physiotherapy judge. Okay. Thank you, Madam. To mark the end of the technical session 2 of the 14th International Research Conference KDU, I would like to invite Mr. Udish Jayasinghe to deliver the vote of thanks.
Good afternoon, all. On behalf of the Department of Physiotherapy, Faculty of Allied Health Sciences, KDU, it gives me an immense pleasure to deliver the vote of thanks to all the dignitaries assembled here. I would like to thank the chair, Professor Charitha Goonasekara, the Dean, Research and Development Unit for successfully concluding the session. I would like to thank our two judges who attend this session, Dr. Sachitra Ilanganthilaka in the Department of Clinical Sciences, Faculty of Medicine, KDU, and Consultant Rheumatologist in KDU, and Mrs. Lakshmi Jailath, Senior Lecturer at Department of Allied Health Sciences, Faculty of Medicine, University, who submitted and presented their research to the 14th International Research Conference, KDU. I hope all of you had a wonderful experience. Also like to thank all the participants who participated to the conference either on site or online. Your interest in research is highly appreciated. Last but not least, I would like to thank Dr. Darshana Kottachi, Dean, Faculty of Allied Health Sciences, KDU, and Dr. Vasana Weerarathne, Faculty Coordinator of IRC 2021, and Department Coordinator of IRC 2021, Mr. Weerarathne, Department of Physiotherapy, FHS, KDU, and all the academic and non-academic members of the Faculty of Allied Health Sciences for your immense support and the guidance to make this event a success. Thank you.
Thank you, Dish. With that, we would conclude the technical session 2, parallel session 1, 14th International Research Conference KDU 2020.